Hello, everybody. My name is Anthony Ford, and I'm an emergency medicine physician by training. I'm also a NAUI course director for scuba divers. That essentially means that not only do I train people to become scuba divers, but I also train people to become scuba instructors. So both of those are passions of mine. I will be wearing two hats today, and I will start with the first hat being affiliated with scuba diving. The National Association of Black Scuba Divers is an organization that was founded in 1991 by Dr. Jose Jones and Mr. Rick Powell. These are individuals who found that they did not have a lot of individuals that looked like them who were diving. Once they became aware of other divers of color across the country, they decided to organize and unite and form the National Association of Black Scuba Divers. NABS, as it is affectionately called, has 17 chapters across the United States, from New York to Michigan, from California to Texas, from Georgia to Philadelphia. So invariably, there should be a chapter club near you. NABS also sponsors an annual meeting in November to celebrate diving and to conduct business. This is really an opportunity for us to fellowship with divers we haven't seen in a while and to make sure that the business is still flowing appropriately. Last year, we actually went to Egypt, which was impressive. It was the first time that we had been out of the Caribbean and traveled internationally to another continent. It was impressive to see over 117 divers of color in the water all at the same time. That was nice. NABS also has an annual youth summit that introduces STEM-based learning combined with scuba diving. So those of you who have children, grandchildren, nieces, and nephews, if you are interested in participating in our youth summit, please reach out to us. We'd love to have you become a part of what we're growing. NABS also has an AquaCorps committee. This is the dive leadership arm of the association, and it ensures dive safety for the members. The AquaCorps is comprised of dive masters, instructors, course directors, etc., and its primary responsibility is to make sure that the membership is educated appropriately with regard to scuba diving and scuba diving safety, as well as making sure that the members are safe in general when we take our exotic trips. I'm actually fortunate enough to be president of NABS for 2020. You can visit our website at nabsdivers.org. You can also visit us on Facebook, where you can interact with other divers of color. All right, now back to my physician hat. Today's topic is going to be on ear barotrauma, which is something of significance to me as both a physician and a scuba diver. This picture represents the shipwreck, the Spiegel Grove in the Keys in Florida. It is one of my favorite places to dive. It's where I take students to train often. You can see that it is sunk in about 110, 115 feet of water. You can see the marker buoys at the surface where the boats tie in. And to get down to enjoy this beautiful wreck, we usually dive around the middle section of the wreck, which is in about 80 feet of water. In order to enjoy the wreck, we have to enter into a hyperbaric environment, which means that we are in an environment that has greater atmospheric pressure on us than we would at the surface. To get down and enjoy the wreck, down at about 80 feet, which is about where this is, we see the beautiful crustaceans, the marine life, the animal life, the ecosystem that exists. This is our hyperbaric environment. This, again, is about 80 feet of depth. And whenever you are diving that deep, you are subjected to changes in pressure. Diving involves exposure to a hyperbaric environment. These changes, in particular, as we talk about the ear and pressure, can result in injuries to three parts of the ear. And we'll go over those in just a little bit. Understanding the anatomy of the ear can help in comprehending the symptoms that divers may experience. This may be important to you as physicians if you have a patient that comes into your urgent care center or primary care office or even in the emergency department and they say that they've been diving. Understanding what happens to them when they dive can lead credence to what may be occurring with them symptomatically. By the end of this presentation, you should be able to describe the anatomy of the ear, which again may not be challenging for this particular audience. We'll discuss the impact of diving to each part of the ear. We'll discuss the symptoms associated with ear injuries, and we'll discuss treatment options for injuries sustained to the ear, and discuss potential complications of ear barotrauma. So I always like to start out with the anatomy. That seems to dictate where we go and what we do. The ear, for the purposes of this presentation, are broken into three parts. There's the outer ear or external ear, the middle ear, and the inner ear. And we defined those regions by the tympanic membrane, as well as the round and oval windows. So everything lateral to the tympanic membrane is the outer ear, and the region between the TM and the round and oval windows are the middle ear, with the inner ear being responsible for auditory and balance. Again, I love pictures. The inner ear has been described in different ways as we look at the three semicircular canals, anterior canal, posterior canal, and in this pictorial, they describe it as the lateral canal, whereas on this one, it's the anterior, posterior, and horizontal canals. Even though they are labeled differently, we're essentially talking about the same semicircular canals. All right, let's talk about the outer ear for a second. The outer ear comprises the auricle and the external auditory canal. These structures function as a funnel and resonator to amplify acoustic signals. Wearing a rubber hood increases the bacterial growth within the canal. Sometimes scuba divers will wear neoprene or rubber hoods to keep them warm. If you've ever been diving, or for those who dive in the Northeast, off the coast of New Jersey or New York, as well as those who dive in the Pacific Northwest, those waters are extremely cold. So divers will wear protective gear to keep their ears warm. One of the downsides of wearing the hood to keep your ear warm is that you may trap water and the bacteria within it within the ear canal. This can lead to an infection. Frequent exposure to water may wash away the normal acidic environment in the canal and allow for more alkali-friendly bacteria to grow. This can lead to otitis externa. Symptoms of OE include itching, pain, tenderness, and drainage. So again, if you have patients who come in to your place of business and have these complaints, please don't forget to ask them if they've been scuba diving. Treatment includes irrigating the canal, and you may use an antibiotic or steroid solution on a wick. Complications of OE include conductive hearing loss due to prolonged inflammation to the overlying skin. If the lesion is circular, then shrinking scar tissue may cause occlusion of the canal, leading to hearing loss, especially if this is a circumferential scar. You can actually scar down the canal, again, resulting in hearing loss. Cerumen obturans can occur if dry wax is exposed to water. The wax may swell and occlude the canal. Simple treatment is just removing the wax. Barotrauma of the auditory canal itself. If the auditory canal is closed during descent by a dry suit hood, meaning that as the diver is putting on his hood and starts to descend, the pressure within the canal will increase. This pressure will stretch the tympanic membrane outward and cause pain. So if you're having patients who are coming in with ear pain, please again ask them about their scuba diving activities. The change in pressure can cause dilatation of the surrounding blood vessels and lead to bleeding within the canal itself. Forceful valsalva may cause a ruptured tympanic membrane. In scuba diving, especially within the middle ear, the eustachian tube is crucial for equalizing the pressure between the outer ear and the middle ear. One of the ways that divers can restore that balance is through a gentle valsalva, where you pinch your nose and you blow into your nose. Hopefully this will open up the canal and equalize the pressure. If divers tend to do this forcefully, you can actually generate enough force to rupture the tympanic membrane. This is a graphic showing hemorrhage and bleeding into the external auditory canal. We talked about the vasodilatation of those vessels. We talked about the rupture of those vessels. This is what that can look like as you see hemorrhage on the superior and inferior aspects of the canal itself. So again, if you're having patients who come in with bleeding from the ear canal, please ask about their diving activities. Signs and symptoms of barotrauma of the outer ear include pain during descent as they're going down, bleeding from the canal when the hood is removed, and reduced hearing. Prevention: you can wear a thick cap under the dry suit hood to create a reservoir of air, or what is most commonly done, you can fill the canal with water prior to descent. So the diver simply separates the hood from the side of their face, allows some water to come in, put it back. Although this may lead to otitis externa, as we talked about earlier, it may be a means of preventing barotrauma to the outer ear. Treatment includes washing the canal with lukewarm saline and cleaning it with an ear suction pump. If the TM is perforated, diving cannot continue until the patient is evaluated by an ENT physician. And we'll talk about the time frame of that in just a little bit. I usually like to put in a break slide just so that we can break the monotony, so that people don't tend to tune out to your voice when you're talking over and over again. But in this scenario, we will continue. This again is our faithful picture of the anatomy of the ear. This time we're going to focus on the middle ear. For the middle ear to function properly, the pressure between it and the external auditory canal must be equal, which is what we talked about earlier. When ambient pressure or outside pressure changes, it must be compensated in the middle ear by gas movement through the eustachian tube. So the eustachian tube is essentially your release valve. That's where the pressure gets transmitted from the outer ear to the middle ear and out of the middle ear, preferably through the eustachian tube. During descent, the increased pressure can cause vasodilatation, edema, and vascular rupture with bleeding into the tissue. This is exactly what we talked about in the external auditory canal as well. Local tissue deformation may trigger pain receptors. So one of the primary complaints that the patient will have is just simply pain. During ascent, which means as the diver is coming up out of the water, if the gas cannot escape the middle ear as ambient pressure drops, then the increased pressure on the blood vessels can cause ischemia. And again, this is a graphic pictorial of what that looks like. On the previous version of this, we saw bleeding into the external auditory canal. This time we're seeing bleeding within the middle ear. So those big dark areas are hemorrhage on the top portion of the middle ear and bleeding into the eustachian tube. Compression barotrauma of the middle ear is the most common form of barotrauma of the ear. On descent, the tympanic membrane will be pushed inward until an adequate amount of air is added to the middle ear through the eustachian tube. If no air enters by 4 feet of water, the pharyngeal muscles, which are the ones that you typically use to open the eustachian tube, will not be strong enough to open the tube. Typically what we tell divers is to wiggle your jaw, or you can swallow, and that's enough to open up the tube to equalize the pressure. However, if this is not done by at least 4 feet of water, you may need to do a valsalva, which causes increased pressure through the ear. It is therefore important to begin the process of equalizing immediately upon descent, and this is a training issue. One of the things that we train students to do, the moment that you hit the water, go ahead and start equalizing during your descent. You want to avoid having to use a valsalva unless necessary. Some studies have shown that the tympanic membrane can rupture between 16 and 69 feet of salt water. Again, that's a wide range. The strength of the TM decreases with increasing age. So the older that we get, the weaker that membrane becomes. TMs with scarring from old injuries can rupture at 10 to 26 feet of water. So you may get older patients who've been diving who may encounter a tympanic rupture even at more shallow depths. This is a picture that I show divers to show them what we see when we look inside with an otoscope. So you have the normal eardrum, and then you have the perforated eardrum. These again are consequences of changes in pressure to the tympanic membrane. And I like this picture because the patient in the picture looks like me, and I don't see a lot of pictures like that. I'm not sure if this picture is showing up well on your screen, but I like it as a description of what the tympanic membrane looks like through increased pressure changes. So as we go from top to bottom, grade 0 is a normal tympanic membrane at the top left. Up underneath that is grade 1, where you see mild injection of the tympanic membrane. Grade 2, you can see slight hemorrhage with more significant injection. Grade 3, you may see injection of the entire tympanic membrane, and this is typically what we see when we look into the ears of kids with real bad otitis media. Grade 4, you can actually see rupture of the blood vessels, resulting in blood at the bottom portion of the TM. And then grade 5, you actually see perforation of the tympanic membrane. So I wanted divers to know what we are looking for when we look into their ears. All right, signs and symptoms include ear pain and fullness during descent. So as the divers are going down, they may experience increased pain, reduced hearing, and possible tinnitus. If the TM is perforated, you can get intense vertigo, nausea, and vomiting. Prevention, teaching and training should emphasize early and correct general pressure equalization techniques. Again, this is a training issue to make sure that divers are able to perform this correctly so that these injuries don't occur. The Frenzel technique, pinching your nose, keeping your mouth closed around a mouthpiece, and moving your jaw forwards and down or sideways. Scuba divers breathe in and out through a device called a regulator, which is something that they keep in their mouths at all times to breathe in and breathe out. So the regulator should be in their mouths at all times. All they have to do is just pinch their nose and move their jaw side to side, forwards or side to side. Descending feet first also enhances the ability to equalize because of pressure changes within the body. Oral decongestants may reduce the incidence and severity of middle ear squeeze in novice divers. One of the things that we caution new divers about, and divers in general, is that the effects of the decongestants may wear off towards the end of the dive. So while it may work at the beginning of the dive, divers need to be aware that if it does wear off, they may have problems ascending without pain. Most cases of middle ear barotrauma will clear spontaneously. Diving should not be resumed until otoscopic findings, hearing, and eustachian tube functions have returned to normal. A ruptured TM may allow water into the middle ear, causing an infection as well as intense pain. Treatment includes rinsing the canal and most likely antibiotics. The ear may take a minimum of 3 weeks to normalize. This is important so that we can caution divers not to get back in the water. Scuba divers are an enthusiastic group and they always want to get back in the water as soon as possible. It's important that they take the time to let the TM heal, and 90% heal spontaneously in 3 months without any surgery at all. I actually had a student who perforated her tympanic membrane in 10 feet of water in the pool. So the good thing is that her eardrum did heal without any surgical intervention, although unfortunately she did not return to diving. All right, middle ear equalization becomes difficult with repeated ascents and descents. We call this yo-yo diving. Divers going up and down and up and down. Usually that's a function of poor buoyancy control. Divers are taught to become neutrally buoyant and not go up and down unless absolutely necessary. When divers have difficulty maintaining neutral buoyancy, they tend to yo-yo dive in the water. This stress irritates the lining of the eustachian tube, causing it to swell. This swelling may interfere with equalization between the outer and middle ears. The inability to equalize, of course, will cause increased pressure within the middle ear and potentially cause rupture of the tympanic membrane. So this, again, is a training issue. It's adamant, or it's crucial that we train our divers to achieve neutral buoyancy. This is a pictorial of a ruptured tympanic membrane. As you follow the arrow going from the middle ear to the outer ear, you can see that the increased pressure, as the pressure is greater within the middle ear than it is within the outer ear, can cause rupture of the tympanic membrane. Signs and symptoms include ear pain during ascent as they're going up. They may experience pain as well as tinnitus and vertigo. Prevention, avoid yo-yo diving, which we've talked about, training to improve diving skills and buoyancy, and avoid diving with an ear or sinus infection. This is crucial. We are aggressive about making sure that divers know that if they have the sniffles, runny nose, cough, congestion, etc., they should avoid diving. Most will resolve spontaneously, and again, diving should not be resumed until all functions have returned to normal. Alternobaric vertigo. Interesting category. It's something that I discovered through my reading and research. It occurs when there is a difference in pressure between the two middle ears, so not just one ear, but both ears. This results in asymmetrical pressure stimulation of the vestibular apparatus. It is more prevalent in experienced versus novice divers. And during ascent with the body in the vertical position or upright position, the sensation of spinning will be towards the side of the poorest eustachian tube function and higher middle ear pressure. This is interesting because this is something that my wife deals with. And she was thrilled to know that what she was experiencing wasn't in her head. It actually had an official medical name. You can get disorientation, vomiting, and an inability to follow safe decompression procedures. When divers are ending the dive and they come up at the end of the dive, they're taught to do what's called a safety stop. which is where you stop at about 15 feet for 3 minutes to allow your body an opportunity to release the nitrogen that you've absorbed during the dive. If you become disoriented, if you can't tell up from down, if you can't tell whether or not you're ascending or descending, then you may bypass this safety stop, which may lead you into potential decompression issues. You can also get nystagmus as well as ataxia. Treatment, prevention and treatment, diving should be avoided until middle ear equalization can be comfortably performed, and oral decongestants may be used before the dive, again with the caveat as mentioned earlier. Direct trauma to the ear can occur via direct pressure, either a fin, a hand, or an elbow that may inadvertently strike the ear, causing increased pressure within the EAC, which can cause rupture of the tympanic membrane. It's amazing how large the ocean is, but yet how frequently divers seem to continue to bump into one another. This is especially true if the TM is already bulging outward due to poor equalization during the dive. Again, this comes down to training. It also comes down to educating divers to make sure that if they have issues with their eustachian tube, infections, congestion, etc., they should avoid diving. Signs and symptoms include ear pain, vertigo, hearing impairment, tinnitus, and the treatment is the same as other middle ear barotrauma injuries. All right, again, a slight break just so we can break the monotony, but we shall push forward. Now we're going to talk about the inner ear. Again, back to our large netter colored anatomical depiction. All right, the inner ear is comprised of the semicircular canals, which we talked about earlier, as well as the vestibular and cochlear apparatuses. Love this picture, and I use it to describe or show the movement of sound in the inner ear to divers and to students. The air hits the tympanic membrane, causes vibrations through the malleus, incus, and stapes. It strikes the oval window, moving the perilymph, which shifts the endolymph, which causes movement of the cilia within the organ of Corti, which transmits these impulses along the auditory nerve as sound. The inner ear, as mentioned above, is comprised of the cochlea and the vestibular apparatus. The fluid in the inner ear is not compressible. This becomes important with regards to diving. The cochlear aqueduct provides a connection between the CSF and the fluid within the inner ear. This connection allows pressure changes in the CSF to be transmitted to the inner ear, resulting in changes to hearing as well as balance. This means that prolonged forceful valsalva, which increases intracranial pressure, can also increase inner ear pressure. If the middle ear pressure is not equalized during descent, the TM will be pressed inward, moving the ossicles inward, pressing against the oval window and causing the round window to bulge outwards. Impressive amount of physics. The diver senses this as pain and may attempt a valsalva, especially if they're below 4 feet. Repeated prolonged attempts will lead to increased CSF, increased pressure within the inner ear, and rupture of one or both windows. Absolutely fascinating. This increase in pressure may affect the auditory as well as the vestibular components of the inner ear. So again, we teach divers, equalize appropriately. Signs and symptoms include ear pain from poor equalization, vertigo, disorientation, nausea and vomiting, nystagmus, and a sensation that one of the ears may be plugged. They can also develop high-pitched ringing in their ears, possible hearing loss, but fortunately, these symptoms tend to improve over time. Prevention, proper education, and training with special emphasis on gentle pressure techniques has shown to be beneficial. Equalize early and often, certainly before the 4-foot platform. Treatment: if the symptoms of hearing loss and vertigo is severe, then bed rest with slight elevation is recommended. Avoid straining, which obviously increases CSF pressure. Avoid diving for a minimum of 3 months. This is crucial that divers understand how potentially dangerous this can be. And as always, consult your ENT physician. Inner ear decompression sickness. This was something I was not aware of prior to the research for this presentation. I knew about decompression sickness as it relates to the bends, to the joints, to the arms and the legs, but not necessarily inner ear DCS. Symptoms may be the only manifestation of DCS even after shallow diving, which means that this becomes crucial for patients who present to the emergency department or an urgent care center. The cause may be the presence of intravascular gas bubbles or gas bubbles in the endolymph and perilymph. Signs and symptoms include acute hearing loss, tinnitus, vertigo, and unsteadiness. All may be present in any combination. So if you do get any of these patients that present to you, please ask about their diving history. Treatment involves recompression, being sent to a recompression chamber ASAP. This is why this is an emergency. Delayed treatment may lead to permanent damage to the cochlea and the vestibular apparatus. So to avoid these clinical consequences, please be vigilant about the signs and symptoms of inner ear DCS. All right, as we talk about the vestibular system, we again talk about the anterior, posterior, and lateral semicircular canals, as well as the crista ampularis and the cupula. If you focus on picture C on this graph, as movement occurs, there's movement of the endolymph, which shifts the cupula, which stimulates the sterocilia, which translates these impulses through the auditory canal, through the auditory nerve. Sorry. Our sense of balance is comprised of the vestibular system, vision, tactile sensations, and proprioception. A neutrally buoyant diver in darkness must rely on this system. Divers will often do what's called night dives. It's not completely dark, but it's dark enough to where you need a light. It's really like driving at night. You can see where your head beams are showing, but you can't really see well outside of that field of view. So in order to tell their position in the water, they're counting on, divers that is, are counting on their vestibular system being intact. Injury to this system may render a diver disoriented, vertiginous, and nauseated. This may cause panic in the water and lead to a diving injury. So for divers who experience these symptoms, if they make a mad dash to the surface, they can actually develop decompression sickness. Cold water can enter the canal, cold water entering the canal may cause stimulation of the vestibular system as well. If the cold water enters the middle ear as a result of barotrauma, this stimulus is intensified. Usually the symptoms will fade quickly as the water is warmed to body temperature, but with a perforated TM, you do have to be worried about the possibility of an infection. All right, today we were able to describe the anatomy of the ear. We discussed the impact of diving to each part of the ear. We discussed the symptoms associated with the injuries. We discussed treatment options for injuries sustained to the ear. And we also went over potential complications of ear barotrauma. And this last picture is one of my beautiful daughter who is descending perfectly. She's horizontal in the water. She is attempting to equalize, and hopefully she won't develop any of the signs and symptoms of ear barotrauma that we've been talking about. Thank you very much.